Hello, everyone, and welcome to the debate. What we're doing now is just giving everybody time to log in from the previous debate. So we'll be getting started in just a minute or two. Once again, hello, everyone, and we're just waiting a couple of minutes for people to have a chance to join in from the previous debate. So I think we're just about ready to get started. So what we'll do first, welcome everyone to the debate before we get started on the polling. The debate topic today is whether or not we should screen all adolescents for chlamydia and gonorrhea, or only screen those who report being sexually active. So let's see where everyone stands now before the debaters get going. So you should see a poll now on your screen. And while we're looking at the poll results coming in, I'll introduce today's speakers. Taking the pro side will be Dr. Gail Bernstein. She is the Erie County Department of Health Commissioner and a clinical professor of pediatrics at the Jacobs School of Medicine in Buffalo, New York. Her research focuses on improving provider practices for confidential adolescent sexual health services and preventing drug overdose deaths. Dr. Bernstein is also co-chair of the Erie County Opioid Task Force, where the number of opioid-related overdose deaths has been decreasing since 2017. And taking the con side will be Dr. Natalie New. Dr. New is a professor of pediatrics and the medical director for the New York City STD Prevention and Training Center at Columbia University Medical Center. Her research and clinical work has focused on STDs and HIV in adolescents. So the poll has come in and we're split about 60-40. So I guess it's good that we're a virtual audience and we're not tightly packed where this could quickly deteriorate into violence. So now we'll just move on and let Gail start us off.
All right, I'm a non-violent presenter. So hello, I am Gail Bernstein, the Erie County Department of Health Commissioner, a pediatrician, an adolescent medicine physician, and a mother of an adolescent and young adult sons in Buffalo, New York. So I will argue for the pro side of universal chlamydia and gonorrhea screening for all adolescents. So we all know that the medical literature, and I'm sure personal and professional experience, that adolescents and young adults are engaging in sexual behaviors. We also know that from the medical literature and professional experience that there is a high chlamydia and gonorrhea prevalence among adolescents and young adults. National recommendations to only screen youth reporting sexual behavior does not work because providers are not asking, providers are not discussing confidentiality, and adolescents and young adults are not disclosing sexual behavior. So according to the National Survey of Family Growth, many adolescents have had sexual intercourse at least once. According to an NSFG brief published in May of this year, in 2015 to 2017, among never married 15 to 19-year-olds, 42% of females and 38% of males had engaged in sexual intercourse. By age 17, 53% of females and 48% of males had ever had sexual intercourse. And by age 20, the percentage increased to 79% of females and 77% of males. Although those of us working in sexual health field all know that adolescents and young adults have high chlamydia and gonorrhea prevalence, to be complete, I will present this bar graph showing NHANES national estimates of chlamydia prevalence among sexually active 14 to 39-year-old females by race and Hispanic ethnicity and age group from 2013 to 2016. Among sexually active females aged 14 to 24 years, the population targeted for screening, prevalence was 4.3%. And of course, prevalence varied by age and race ethnicity, with the highest prevalence among the 14 to 19-year-olds at over 5%, and among Mexican American females at 10%. Currently, CDC and other national guidelines recommend chlamydia and gonorrhea screening only young people who report sexual activity. So, how was that going? Well, not so good. These National Committee for Quality Assurance Healthcare Effectiveness Data and Information Set, or HEDIS data, show the percentage of 16 to 25-year-old females who were identified as sexually active by administrative data like billing or diagnostic codes, and who had at least one chlamydia test during each measurement year. Obviously, we are below the bar and not making much progress. In 2008, the 16 to 25-year-old female chlamydia screening rate in a commercial HMO was estimated to be 42%. 10 years later, in 2018, it only increased to 51%, which is less than 1% per year. For Medicaid HMOs, the chlamydia screening rate was 55% in 2008 and only increased just 3 percentage points in 10 years to 58%, which is not much progress. And what is worse, these are extreme overestimates in the first place, because sexually active females who do not receive any sexual health services are not counted in these statistics. So people who know me will tell you that I'm generally an optimist. However, based on national data and my own personal experience trying to change provider behavior among my own pediatric colleagues by engaging them in quality improvement strategies to improve their chlamydia screening, I think at a national level, public health will never see success in routinizing a sexual history and chlamydia gonorrhea screening for sexually active adolescents and young adults in primary care. In 2015 to 2017, I worked with the American Academy of Pediatrics, the New York State Department of Health, and the New York City STD Prevention Training Center to implement a QI project to routinize sexual history taking and improve chlamydia screening among adolescents and young adults. We worked with a total of 7 Buffalo area pediatric or family medicine offices over the course of 2 years with a structured QI protocol and a QI nurse. Working with just these 7 offices to change their practices so they would routinely ask a sexual history was successful and incredibly labor intensive. At the end of the QI project, each lasting 9 months with 5 PDSA cycles and an abundance of time and trauma drama, we fulfilled our mission where sexual history was documented at 90% of adolescent young adults visits. Achieving this goal for just 7 local offices took an extraordinary amount of work and stress. And honestly, I have no idea if these offices even sustained their practices. To explore a more nationally generalizable project, the following year with OSTL funding, our New York group assisted the American Academy of Pediatrics with a national virtual QI project to routinize a sexual history and chlamydia screening in 13 pediatric offices across the country. At the end of the 6-month QI project with 4 PDSA cycles, as the table illustrates, the percentage of well visits with a sexual history increased from 70% at baseline to 96% at cycle 4. However, for acute care visits, which for adolescents are the majority of visits, the proportion of visits where sexual history was taken increased from baseline of 22% to only 44% at PDSA cycle 4. And believe it or not, adolescents and young adults do not always tell the truth. Even if the provider does ask about sexual behavior, for many reasons, youth may not always disclose. An analysis of the National Longitudinal Study of Adolescent Health Data, where 14,012 young adults reported sexual behaviors in their homes using audio computer-assisted self-interviews and provided urine for gonorrhea, chlamydia, and trick NAT testing. Of the 964 subjects who tested positive for one of the STIs, 11% reported abstaining for sex for over the past 12 months, and 6% who tested positive for an STI reported never having sex. So even if primary care providers ask, many will never know the truth unless they order a test. And I'll turn it over to Natalie.
Well, thank you, Gail. You definitely made a strong argument, but good afternoon, everyone. My name is Natalie New. I am a pediatrician as well, and the medical director for the New York STD Prevention and Training Center. I believe I have the knowledge and the experience to speak about who should be tested for STDs. And I believe that adolescents should only be screened for chlamydia and gonorrhea if they report a sexual activity. So in today's discussion, I will make my case. I will provide you some evidence to support that history-based screening is the best type of program. I'll show you that there are several national guidelines that support this type of program. I'll provide you with some thoughts about why it's important to have a screening program and not just to test. We will discuss some limitations in provider skills that Dr. Burstein already mentioned and how it can impact on STD care. And I'll suggest some consequences that could arise from universal testing. Finally, we'll discuss the cost of universal testing. So here you see in this figure 5 national guidelines for screening for chlamydia. As you can see, the AAP, ACOG, AAFP, CDC, USPSTF all say that give selective criteria about having a history of sexual activity as a key component for screening for STDs. For men, most national organizations only recommend screening high-risk men, such as men who have sex with men. But that requires knowledge that the patient is having sex with a male partner. So you have to do a history. Similarly, the national guidelines for screening for gonorrhea also specify that knowledge of a person's sexual activity is a priority. None of these guidelines suggest universal screening. Here we see in this figure from the National Youth Risk Behavior Survey from 2019 that 34% of youth have ever reported sexual activity. Likewise, by 12th grade, about 56% have had sex. Thus, close to half of the students are not sexually active, but Dr. Burstein will have you test all of them for STDs. Some providers even suggest 3-site testing, oral, anal, and genital. However, as you can see in the figure below, less than 50% of the students have said that they have oral sex, and only 9% are having anal sex. And so why would you recommend screening for everyone when they aren't having sex? As David would say, it's too much testing. When it comes to STD care, it's much more important to have a program than just doing a test for STDs. We need to think big, not just about doing the test. An STD program should be about early identification of sexual health issues. The program should focus on prevention of STDs, unintended pregnancies, and HIV. Overall, the STD program should reduce transmission and lower the community burden of STDs. Having a comprehensive program gives the provider opportunities to identify other clinical and psychological issues related to STDs, and thus creating a time and an area where interventions can be created to help these clients with all aspects of their sexual health. So STD care is not just about the test. It's about having a comprehensive program. Better communication will lead to better care. This happens when providers know how to talk to their clients. From an article by Wimberly, we know that only 55% of providers ask about sexual activity at routine annual exams. In fact, only 12 to 34% ask specific questions such as type of sex or the type of partners. Not asking these questions will lead to missed opportunities for screening and risk reduction counseling. There are many unintended consequences to universal testing. For example, if we do universal testing, it may lead to unlinked episodes of treatment prevention, counseling, or partner notification. This could lead to, in turn, more STDs. And we know with our new electronic medical record, it would be easy to wonder, am I missing something? We can't underestimate, the trauma of getting an STD test. There are many ways it may be traumatic. For young adults, they may worry about loss of confidentiality that was already previously mentioned. Often insurance is linked to their parents, and thus it could lead to some stress between the young adult and their parents. Developmentally also, some adolescents might not be ready to handle the emotional impact of getting an STD test. There may be trauma also in the physical procedure of getting the test. Right now in the COVID pandemic, various testing materials have been impacted. And in fact, in several states, there may be limited supply of the urine-based STD tests, resulting in the need to do penile swabs. That could be very traumatic for our young males. Finally, universal testing could lead to presumptive treatment with antibiotics. We know in the US, we are facing a crisis of drug resistance. In 2017, gonorrhea was listed as one of the top 5 infections of concern for rising antibiotic resistance. Giving so many antibiotics presumptively could lead to even more drug resistance in our country. My final point for this argument in support of testing only those who report sexual activity is the cost-related argument. The CDC STD prevention funding has been flat funded, as you see here in this figure, for the last 6 years. This money is the safety net for people without insurance to get STD tested. With flat funding, how are we going to pay for universal testing? In addition, it's not just paying for the testing, but all that comes with the testing. So clinic hours, nursing time, antibiotics. This increase in care and testing could lead to ballooning costs in an overly taxed system already. It's like throwing out money out the window, as this picture displays. So in summary, the current guidelines do not support universal testing. Screening for STDs should be part of a program, not just about universal testing. Youth need to be connected to healthcare. This alone will result in overall improvement in sexual health. We cannot just focus on the testing. As healthcare providers, our job is to do no harm. There may be unintended consequences to universal testing, such as trauma, loss of confidentiality, drug resistance, which need to be evaluated before supporting such a program as universal testing. Finally, promoting universal testing is cost prohibitive. There are no increase in fundings in the CDC to support such a testing. With public health resources shrinking, should this be where we invest our limited dollars? That's a question that I ask you.
Okay, great. Thanks, both of you. And in my role as moderator, I was supposed to introduce the speakers and conduct the polls and also tell the audience to enter questions in the Q&A section. So 2 out of 3 ain't bad. I forgot to tell everyone to put in questions in the Q&A. What we'll do now, while people are putting in questions, is to move on to the rebuttals. Each speaker will have 3 minutes for their rebuttal. So we'll pass it back over to Gail.
Thank you. So for my rebuttal, I just want to point out that healthcare is always about the money, right? As my esteemed opponent points out. So recent cost effectiveness analysis of chlamydia screening strategies found that universal or opt-out chlamydia screening, similar to opt-out HIV testing for young people, is cost effective and is the only path to finally decrease chlamydia prevalence. So a CDC modeling study published in 2016 explored the cost effectiveness of a patient-directed, universal, opt-out testing strategy for all females aged 15 to 24 years. The authors compared the opt-out testing with the current risk-based screening that asks about sexual behavior and to a strategy of no screening. So asking about sexual activity and the screening and screening only those with a positive response results in only a 30% testing coverage of sexually active 15 to 24-year-olds. The opt-out chlamydia testing strategy yielded the expected annual chlamydia testing coverage of approximately 50% for sexually active 15 to 24-year-old females. This estimate is based on assumptions of 80% insurance coverage, 83% healthcare utilization, and 75% test acceptance among sexually active females. So based on the assumptions and the case-based parameter values used in this study, the total chlamydia prevalence with no screening on the left, which is the no screening strategy on the graph, was 5.2%. When the risk-based screening strategy of screening sexually active females was introduced, which is our current status quo on the middle, chlamydia prevalence decreased to 2.7%. And then when the current risk-based screening strategy was replaced with the opt-out testing strategy of offering testing to all 15 to 24-year-old females on the right, the total prevalence decreased further from 2.7% to 1.2%. It's a 55% decrease, so it's slashing the numbers in half. So although this transmission model is an oversimplification of real-world events and has the limitations associated with models in general with varying magnitudes of uncertainty, it does provide evidence that adopting a policy of universal chlamydia screening youth could increase screening and decrease chlamydia prevalence as a cost-saving strategy. Recently, CDC reported that the COVID-19 pandemic has caused a national shortage of STD lab test supplies. However, more importantly, the COVID-19 pandemic has also caused a shortage of people accessing essential health care in primary care, in ERs, and in STD clinics. Adolescents in general seldomly access health care. Now, it is even worse. So, if we are fortunate to see an adolescent for a visit for any reason, now more than ever, we need to take that opportunity to screen for chlamydia and gonorrhea. So to close, I leave you with two questions. One, what do you think these teens are doing when they are not on their phones, especially in a virtual school situation? And two, do you think this pediatrician will ask this young man with a sore throat if he engages in oral sex with males, females, or both? So thank you, and vote universal screening. I'm going to turn it over to Natalie.
Well, thank you, Gail, for trying to argue the cost effectiveness for testing, more testing. But we only need to look at where we are now in the public health crisis to understand that increased testing is not a public health mandate at present. We recently published this article that looked at the impact of COVID on STD services. We found that during the COVID pandemic, there was a significant decrease in STD services, which included testing for asymptomatic and symptomatic individuals, and a decrease in on-site treatment. Now, during the pandemic, with the impact of COVID on these services, how can we argue that we need increased testing? It just isn't feasible. In addition, if everyone is following the news, we know that our National Organization for Guidelines for STD Care recently published a memo indicating that they are not supporting universal testing. On September 3rd, 2020, the memo came out acknowledging that now is a time to prioritize testing. They indicate that testing should be for sexually active females, so note, getting the history of sexual activity, and also for older women, you need to elicit whether they have a new partner. Again, getting a sexual history. No extragenital testing is supported in women either. For high-risk populations, such as men who have sex with men, the CDC supports rectal testing over pharyngeal or even urine-based testing, so even more limited testing in our high-risk population. This requires that the provider get a sexual history first. So I believe that I've provided sufficient argument for my point here today, that STD testing in adolescents should be based on the sexual history. Universal testing is not necessary, nor is it supported. Finally, I'd like to acknowledge the help that I got from my fantastic program coordinator, April, who helped me with these wonderful slides, and also Gallery, who is our program director for the STD Prevention Center. Thank you.
Great. Thanks to both speakers for wonderful arguments today. So now we'll move on briefly to audience questions. So I think one of the first questions is for Natalie regarding long-term impacts of STDs such as infertility. What are your thoughts about the quality of life impacts and costs that could be averted by early detection through screening?
So I'm not saying don't screen. I'm saying get a sexual history first. And so I think that yes, providers don't do good sexual histories, but we can't just fall back on we're unteachable. We're physicians, we're providers, we've been doing this for a long time. We're teachable. Anybody is teachable. And we can teach people to get a sexual history and still do the testing.
Okay, and here's another one for you, Natalie. How could testing lead to drug resistance if you were only treating based upon a positive test?
Well, so it was a little bit of a stretch of my argument, but so my stretch of an argument was that if we're doing universal testing and if people come in and they're very, very worried that maybe it might lead to providers just providing more antibiotics regardless of the test, and not just relying on the test results for giving treatment. So more empiric therapy based on patient anxiety rather than really getting a sexual history and understanding the risk.
Thank you.
A little tongue-in-cheek.
Here's one for Gail. What do you think about the preferences of the patients? And is this, could your argument be forcing them to do things that they really don't want to be? Like not everyone would want to be tested.
Right. So with an opt-out testing strategy, everybody is offered a test and people who don't want it can just opt out. No big deal. So people have a choice.
Do you think teens, am I allowed to say anything?
Sure.
Do you think teens would feel empowered to tell their physician they want to opt out of the test?
Yeah, hopefully, and if they have a good relationship. Also, it could be done in a confidential manner where teens are given, offered to go to the toilet, given a cup, and then, they can do with it whatever they want. So, I mean, there can be different strategies about how to approach this.
Okay, here's one that might be good for both of you. What if a patient does not feel comfortable in providing a sexual history, but might be at risk? We'll start with Gail.
That's why it's, that's why I'm advocating for universal opt-out testing. So everybody is offered a test. And so just through the modeling study, they were able to show that we were able to identify a lot of disease. And then, people chose whether they wanted to get tested or not. And so in this study, there were very few people that were not sexually active that opted in for testing. So this is a great way to ensure that everybody who needs a test will get a test.
I think, though, also, if somebody's uncomfortable talking about their sexual history, that is something that needs to be addressed. And also, you can help them in some ways in discussing it. There are also other tools that are available in the clinic. So everyone now, especially, we're all used to registering before you come in, do your COVID, signs and symptoms. You can send people a survey before they come in, and or an anonymous ACASI, like use an electronic tool. Tell us if you're having sex, who you're having sex with. And that way you're giving the information, even if you feel uncomfortable with the face-to-face provider discussion. I think, though, too, we need to encourage our youth to be able to have a conversation about sex. I mean, they should, there might be other things that could be addressed if they're uncomfortable discussing that, especially in a clinical setting.
Right. And offering an STD test could be an icebreaker, a way to start the conversation.
Okay.
Like,
Gail, here.
Cocktail. Your STD test, your cocktail.
We'll do one more and then move on to the final poll. Gail, what would you think about a targeted approach, maybe geographically based opt-in, opt-out type preferences, where depending on the local community, whether or not opt-in or opt-out would be available, rather than it being national?
Well, I think when you, start to create specific guidelines for, certain areas of the country, it gets a little sticky and confusion. I mean, we're looking at this as a great strategy to identify undiagnosed disease, making sure that everybody who is infected gets identified and treated, and through partner notification will break the chain of transmission. So I think this is really a healthy strategy for all areas of the United States.
Thanks. And thanks again, both of you, for wonderful presentations. And we'll start the polling now to see where the audience stands now on this issue. And if either speaker has any other concluding remarks to make while the votes are coming in, feel free.
Natalie and I are really friends.
No way.
Until today.
But in regards to your last question, I think we can't bring in profiling into sexual history or sexual health care. Like, everyone should know how to talk about sex, and everybody just ask my children. And providers should, really need to teach our providers how to talk about sex better, in general.
Right, because there's pregnancy, right? I mean, that's more difficult to treat with than just azithromycin or a shot of ceftriaxone if it's undesirable.
Okay. Well, thanks again, everyone. Looks like the votes are in. And Gail, I think technically you swung 1% to your way, but your victory is not statistically significant. So, both of you winning is in the cup.
What are you, a health economist or something?
So I guess with that, we will end the debate and this presentation. And thanks again to everyone for joining. And thanks again to our wonderful speakers.
Thank you so much.
Bye.